Good evening. My name is Dana Sear, and today we're going to be talking about the uncertainty and illness theory by Merle H. Mitchell. Before we dive into this theory, let's first be introduced to Merle H. Mitchell herself. Here I've provided a timeline of some key points in Mitchell's education and some of the awards that she's received, as well as some accomplishments that she has had in her career. A few of the most important things that relate to this theory are her education and work experience. She completed her Bachelor's of Science in Nursing at Boston University, followed by her Master's of Science in Nursing at UCLA. Upon the completion of her MSN, she began teaching nursing at UCLA and simultaneously completed her PhD in social psychology at Claremont Graduate University. As far as the theory, her dissertation, which was the Perceived Ambiguity in Illness Scale, was the basis used for her Uncertainty in Illness Scale and theory. Mitchell then spent several years teaching psychiatric nursing and served as division head of the mental health division at the University of Arizona. What is the uncertainty in illness theory? There's two parts to this theory. There is the original theory and there is the reconceptualized theory. The original theory was that it served as an explanation of how patients cognitively structure a schema of the subjective interpretation of uncertainty with treatments and outcomes. The desired outcome is a return to the previous level of adaptation or functioning. This similarly relates to the reconceptualized theory as we see. So the reconceptualized theory addresses the process that occurs when a person lives with an uncertain feeling in regards to a chronic illness or with an illness that can potentially reoccur. The desired outcome for this would consist of a growth to a new value. So we'll see this in the next slide as we look at kind of this diagram of how the theory works. So here's an overview of the diagram. You can see that there's lots of arrows pointing into a direction, and our endpoint is adaptation. But in order to get to adaptation, we have to go through these kind of different key points. We start with our cognitive capacities as well as our structure providers. You can see that there are these positive and negative in parentheses. So when our cognitive capacities are used positively as well as the structure providers, we fall into this category of stimuli frame. This consists of a symptom pattern, familiarity of an illness, and the congruency. So how is it relating to other people possibly who have had this illness, and kind of how are they affected? We then flow into this next part, which is the uncertainty. People not knowing how is this illness going to affect them mentally, physically, how's it going to affect them in the long term, the short term? Do they have a prognosis? Is the prognosis good? Is it poor? There's a lot of these factors that go into uncertainty when we're diagnosed with something that maybe we don't know anything about. We see this a lot in cancer, even though it seems like something that is quite well known. As far as when we're actually diagnosed, there is a lot of variety and uncertainty that happens with it. We next flow into an inference illusion. So this splits into how a person perceives their illness. Are they going to see this as a danger, or are they going to see this as an opportunity? So you can see now that this splits off into two different coping mechanisms. With danger, we see people mobilizing strategies and effect control strategies. So maybe they're trying to find something good or something safe in a way to keep their mind from thinking that this is a danger to them. And while it may be in a sense of medical terminology and just having an illness and it affecting your body, they still have to play a fact with those mental kind of coping mechanisms. As far as for the opportunity, we see that people tend to go to a buffering strategy. So they kind of find that middle ground and maybe find a way to learn from this experience. but both lead into adaptation of them having to kind of change a little bit in order to figure out how to deal with their illness. So some of the benefits of the inserted human illness theory is that it provides like a formal education to the patient about their illness. Usually when they go in, they have, in some cases, no idea about this illness. Maybe they've never heard of it, and you're being told all these things that are going to happen. But as a healthcare provider, we need to be able to educate our patients about their illness so that they can understand. It also provides a cognitive resource for comprehending the illness. So again, this kind of falls into being educated about it and allowing them to better understand exactly what is happening to them. It constructs a meaning of illness-related events. So, they know to expect a certain symptom maybe later down the road. Maybe they have knowledge of things that they need to look out for, or things that are just a part of the disease and they're not really concerned. So I think all of this really reduces illness uncertainty. So this is an example of the uncertainty in illness scale. This can vary depending on patient population, diagnosis, just a lot of things. So we can see these questions. There were a few of them, I won't go through all of them. But the first question, I can predict how long the child's illness will last. And then you proceed to fill out, do you strongly disagree, do you strongly agree, or do you not know? Okay. Some of these other questions, it is unclear how bad my child's pain will be. These are things that us as healthcare providers can reflect on to see how are we effectively communicating with our patients and their families about their illness or child's illness, and are we clearing up that uncertainty? Here's another example. Sorry for the blurry, but I'll go through and kind of read again. I'm unsure if my illness is getting better or worse. The doctors say things to me that could have many meanings. It is difficult to know if the treatment or medications I'm getting are helping. So you can see that also with these questions. If you say you strongly agree, then you have a lot of uncertainty. If you strongly disagree, it's most likely that you're understanding your illness, that you've been properly educated, and all following. So some of the limitations that we see with this theory is that in most cases, we see limitations when the theory is used incorrectly. There can still be a barrier between the patients and their knowledge of their own illness. And that can cause, the lack of knowledge can result in increased fear, anxiety, and stress for the patient due to the fact that they may not be able to clearly understand what is happening to them, how their illness will affect them, like I said, in the long term, for the short term. Do they have a prognosis? Is it good? Is it poor? And how is their illness going to affect them mentally and physically? These are all things that I feel are very important to communicate clearly with your patient to eliminate this uncertainty. So, kind of flowing into this idea of using this theory in direct patient care, we are being able to explain how an illness may affect the patient, being able to provide emotional support based on what the patient needs now or what they will need in the future, maybe as their illness progresses, and kind of what are they going to need, directly created around their situation. Being able to educate the patient's family members if the patient desires, and being able to tell the family how they can help them through the diagnosis. We also see that it can be caused or it can be used as a comfort measure for patients who are carrying anxiety and fear with their diagnosis. If you're telling somebody that they have incurable cancer, their first thought is, oh my gosh, I'm dying. Like, what am I going to do? How long am I going to live? People have all these questions, and if we're able to answer them, then it can serve as be very comforting for somebody to be able to fully understand everything that's going on. personally, my point of view on why the uncertainty in illness theory is important in nursing practice, I really think that it builds trust between providers and patients. If you have somebody who is telling you that you have an illness and they're like, well, here it is, deal with it. I don't know anything about it. Here you go. If I was that patient, I would be terrified. But if we have well-educated providers who are being able to clear up this uncertainty with patients, then it builds a lot of trust. And again, with serving as a comfort measure to help patients better understand their diagnosis, it really does help. They also become a trusted individual in a patient's life when they have questions about their symptoms, disease, and or prognosis. Um, so in a case that a patient has a question, they're able to go to us as nurses or maybe a doctor and feel that their questions are valid and that they can get the best answer possible. Maybe it's not what they want to hear, but it's clear and it doesn't remove any uncertainty. It also creates a clear communication environment and helps to avoid misleading information and false facts. So I think this all falls back on really just being educated about, what you're telling your patient. And is it actually true, or is it something that maybe someone told you and you have no idea if it's true, but you're going to tell your patient anyway? That's not good. That's where the trust falls. So thank you so much for listening. I hope that I was able to provide a good kind of explanation as far as what this uncertainty and illness theory does and what its purpose is and how it can be very beneficial as a nurse or even as any sort of healthcare provider.